Hello and welcome. My name is Jordan Watley, and I'm a practicing board-certified pediatric gastroenterologist in Charleston, South Carolina. And I'll be speaking with you today about cow's milk allergy in infancy, prebiotics, probiotics, synbiotics, gut dysbiosis in infants experiencing cow's milk allergy, and the current scientific literature regarding the use of amino acid formulas with synbiotics in the management of cow's milk allergy.
So what is cow's milk allergy in infancy? Well, cow's milk allergy, which is abbreviated CMA, in infancy is a hypersensitivity reaction to proteins in cow's milk, both casein and whey proteins. CMA has also been known as cow's milk protein allergy or CMPA, cow's milk protein intolerance or CMPI, or food protein induced allergic proctocolitis or FPIAP. Hypersensitivity in infancy is typically non-IgE mediated, which is unlike the immediate reactions that we see in typical IgE mediated food allergies in children, adolescents, and adults. The non-IgE CMA in infancy often presents with less specific symptoms like frequent spit ups, fussiness, poor feeding, constipation, diarrhea. And sometimes infants can present with streaks of blood in the stool, which can certainly be a more obvious manifestation of CMA. Though non-IgE mediated CMA in infancy is the most typical type, IgE mediated CMA can occur in infancy, though less commonly, with symptoms of hives, wheezing, and rarely anaphylaxis. Infants can also have a mixed type CMA involving components of both IgE and non-IgE mediated processes. So an example of this would be eczema worsening with cow's milk exposure. Um, and we know that CMA is fairly common in infancy, with an estimated 2 to 3% of infants experiencing cow's milk allergy. Thus, cow's milk allergy is a common reason for infants seeing both their pediatricians and for seeing pediatric gastroenterologists like myself. And typically, CMA first manifests in the first few months of life, and it often will resolve by 1 year of age. It's also very important to note that CMA is thought to be an uncommon occurrence in exclusively breastfed infants. Now let's move on to the diagnosis and management of cow's milk allergy. And as a note, I adapted this discussion from a position paper from the European Society of Pediatric Gastroenterology, Hepatology, and Nutrition, or ESPGHAN, that was published in the Journal of Pediatric Gastroenterology and Nutrition, JPGN, in 2024. It is well known that the diagnosis of cow's milk allergy, particularly the most common non-IgE mediated type, can be quite challenging, really given that the symptoms can be very non-specific. If CMA is suspected, the mainstay of diagnosis is elimination of cow's milk protein. It is typically recommended to first start with a trial of an exclusively hydrolyzed formula, or EHF, for several weeks and then assess the clinical response. Though there is a bit of debate that exists between the step-up approach, which is starting with EFA and then switching to an amino acid formula if there's an incomplete response, and the step-down approach of starting with an amino acid formula, then switching to an EFA if there's good response. At this time, amino acid formulas are typically reserved for infants with partial but inadequate response to EHF. In cases of eosinophilic esophagitis that are triggered by milk protein, which would be considered a mixed type CMA. And certainly in severe presentations like anaphylaxis, cow's milk allergy with associated poor growth and malnutrition, or food protein induced enterocolitis syndrome, or FPIES, which involves a sepsis-like reaction to food proteins. The ESPGHAN position paper does comment that hydrolyzed rice formulas can be considered as an alternative to extensively hydrolyzed formulas, but it should be noted that these formulas are not available for purchase in the United States. And then lastly, the stool testing is really not recommended in establishing the diagnosis of cow's milk allergy. And skin prick testing and even serum IgE testing can show sensitization to cow's milk, but they really do not diagnose cow's milk allergy. So it's important to recognize that as well. Once the diagnosis of cow's milk allergy is established, Cow's milk protein is then eliminated in the diet, and that elimination is recommended to continue for at least 6 months or until 12 months of age, whichever comes first. Infants should start solids at the same recommended time as infants without cow's milk allergy. But infants who are then starting solids should continue to avoid dairy in their solid foods that are being introduced until the time where that elimination ends. Well, first define some terms. The gut microbiota. So this is all microbes, bacteria, fungi, archaea, viruses that are inhabiting the GI tract. We know that the human GI tract contains up to 100 trillion microorganisms, with the highest density in the colon. Then we have the gut microbiome. This is the habitat of the GI tract, and that includes the microbiota that are living there. So essentially, you can think of this as the home where the microbiota live. Then we have gut dysbiosis, and this is a disrupted, unbalanced state of the microbiome. So whether that's overgrowth, paucity, change in diversity, change in metabolic activities, or a change in distribution of the organisms. So what is important about the gut microbiome in early life? Well, we know that the gut microbiota plays a key role in developing the immune system in this period, and we want to keep in mind that 70% of our immune cells are located in the gut. Thus, gut dysbiosis occurring in this critical time frame is linked to long-term health and immune system consequences. Now, how do we define pre, pro, and synbiotics? Well, prebiotics can be thought of as the food for the beneficial bacteria of the gut. These are non-digestible food ingredients that stimulate the growth or activity of microorganisms that are found to benefit the host, which is us. Examples of prebiotics would be fructooligosaccharides, galactoligosaccharides, and inulin. Probiotics are live microorganisms that, when administered in adequate amounts, can benefit the host, again, us. And lastly, synbiotics are a mixture of these live microorganisms or probiotics and the food that they thrive on, the prebiotics. Our current understanding of cow's milk allergy in infancy is that infants with cow's milk allergy do tend to have gut dysbiosis. Infants with CMA often have lower levels of bifidobacteria and higher levels of Clostridia and eubacteria, which is more typical of the adult gut microbiota. Whereas healthy breastfed infants typically have high amounts of bifidobacteria and less Clostridia and eubacteria. So what can we do about this for our babies with cow's milk allergy? How can we influence their microbiome and target this dysbiosis? Can probiotics help? Well, it should be noted that not all probiotics are suitable for use in people with food allergies. However, Bifidobacterium breve, which we know is in abundance in the gut microbiota of healthy breastfed infants, has been studied in infants with food allergy and has been found to be safe in this population. It has also been shown to contribute to reestablishing a Bifidobacteria dominant microbiome, which is important. And what about synbiotics? Well, let's go through the literature. And I think this is so very important that we do this, as there are countless probiotics on the market here in the US. Many of them are not well studied, they're not well controlled, manufactured in a consistent or reliable manner, and many of them make claims that are not supported in the literature. So what I'd like to do is show you here a detailed summary of the literature specifically regarding the use of synbiotics in amino acid formula for the treatment of cow's milk allergy in infancy, so that you have the information you need to make what you think is the best management decision for the children you care for. So this started with preclinical research with an animal model study by Hagi et al., published in 2010, which investigated possible anti-allergic effects of different probiotic bacterial strains in mice sensitized to ovalbumin or egg protein. And they found that Bifidobacterium breve M16V reduced ova-specific IgE, and it also reduced acute allergic skin reactions to ova in this animal model. Then in 2014, Harvey et al. Published their study of a new amino acid formula with Synbiotics that contained this probiotic Bifidobacterium breve M16V and a prebiotic blend of neutral fructooligosaccharides. This study in healthy infants compared this new amino acid formula with Synbiotics with an amino acid formula without Synbiotics and found that growth parameters were comparable between the two groups. And this new formula with Synbiotics was well tolerated over the 16-week study period. Next, in 2018, Candy et al. Published the first multi-center, double-blind, randomized controlled trial studying the effects of amino acid formula with Synbiotics on the percentages of bifidobacteria as well as bacteria from the eubacteria and Clostridia group in fecal samples of infants with suspected non-IgE mediated cow's milk allergy. Fecal samples from age-matched, healthy breastfed infants were used as reference. Over the 8-week study period, the median percentage of bifidobacteria was significantly higher in the test group receiving the amino acid formula with Synbiotics compared to the control group who received an amino acid formula without Synbiotics. The median percentage of eubacteria and Clostridia in the test group receiving formula with Synbiotics was also significantly less than the control group. Then in 2019, Fox et al. Published follow-up data for this previous study, which evaluated fecal percentages of bifidobacteria and eubacteria and Clostridia groups at 26 weeks. They found that this effect of higher bifidobacteria and lower eubacteria and Clostridia in the amino acid formula with Synbiotics group continued over that longer time frame. Next, Woparis et al. Then used 16S rRNA gene sequencing to assess the bacterial compositions in the stool of infants enrolled in these previous studies. They found that the bacterial diversity increased in both the test group receiving Synbiotics and the control group, but that the test group had a more gradual rise in bacterial diversity, which more closely matched the bacterial diversity of the healthy breastfed infant reference group at week 8. Next, Sorensen et al. Published a systematic review and meta-analysis in 2021 of the use of an amino acid formula with Synbiotics in infants with cow's milk allergy, which found that infants receiving an amino acid formula with Synbiotics, resulting in a change in their gut microbiota, had fewer symptoms, a shorter duration of symptoms, fewer infections, fewer medication prescriptions, including antibiotics, fewer hospitalizations. So all of these findings support that an amino acid formula with Synbiotics is quite effective in the management of cow's milk allergy. And lastly, the Espegan position paper on cow's milk allergy specifically acknowledged these research findings and noted that infants prescribed amino acid formula with Synbiotics had a significantly higher probability of achieving asymptomatic management without a long-term elimination diet. The position paper also noted that these infants tend to have a shorter symptomatic clinical course, which is also important to recognize.
So in summary, moderate to severe cow's milk allergy can be managed with amino acid-based formulas. The gut microbiota in early life plays a key role in the development of the immune system, and an amino acid formula with Synbiotics can lead to fewer symptoms, fewer infections, fewer medications, including antibiotics, and fewer hospitalizations for infections. Thank you so much for listening today.